Good afternoon and welcome. Thank you for joining McLaren Northern Michigan today for our third virtual orthopedic education session in this four-part series. Today's session is being presented by Dr. Angus Goetz, orthopedic surgeon. Dr. Goetz will discuss surgical options to relieve pain and reduce limitations caused by arthritis. For the duration of the presentation, all participants have been muted. If you have questions, we encourage you to submit these using the chat feature. These questions are only visible to the moderator. Dr. Goetz will answer as many as he can at the end of his presentation. For additional questions, to schedule an appointment, and for follow-up information, we encourage you to use the links that will be found in the chat box as well. All registrants will receive a follow-up email after the event that will contain these links. Thank you for joining us. Dr. Goetz, take it away.
Hi, welcome back. I'm honored to have the opportunity to talk to you again about arthritis management. If you remember, just as a recap, we talked about conservative measures last time with medications, injections, changes in body habitus and activity levels. But today we're going to talk about joint replacements predominantly. All right. I will here. I'm not.
Click on the slide and then it should work.
Okay. Nope. Click on the slide. There we go. All right. Sorry about that. Thank you. All right. Just in recap, we talked about arthroscopy and synovectomy last time, bone alignment procedures called osteotomies. But today we're going to talk about joint replacements. And so the preamble is my doctor suggests I need a new knee. And a lot of people don't really understand what a new knee means. So today we're going to talk about what a joint replacement is, how it works, and we'll talk about success rates, et cetera. Essentially, a joint replacement is a procedure where we place a cap over the arthritic portion of the bone and eliminate the pain generator, i.e. the damaged cartilage. The benefit to placing these caps, and I have an example and we'll talk a little bit more later. Let's use a knee, for example. When we place the cap over the diseased portion, we removed the diseased cartilage and the torn menisci and other tissues that are injured, and we replace those with prosthetic devices. In this case, the knee. We place a cap on the end of the femur, a cap on the end of the tibia, and in between the two metal components, we place a plastic insert, which makes up for the cartilage and the menisci. The benefit to that procedure is that the metal and the plastic have no nerve endings. Therefore, the pain is relieved. A lot of people don't understand that a joint replacement is not a mechanical device that we insert in your bones and somehow they autonomously work. All your bones, ligaments, muscles, tendons, everything is still yours. What we are doing, however, is replacing those parts that are diseased and are pain generators with new parts that don't have nerve endings and therefore does not hurt anymore. So one of the questions that we have is, do we replace the entire joints? And that is, it depends. Depends on what the disease process is. If people have a knee, for example, and the entire knee is diseased, then you can replace the entire knee. However, not all individuals have global knee arthritis. In this model, for example, you can see that much of the knee is still intact. That's what this white portion is. And you can replace just one part of the femur, for example, i.e. where the patella is, or one part of the femur, which is the weight-bearing part. We call those partial knee replacements or patellofemoral replacements. And so we're only replacing those parts that are diseased. And again, we leave the parts that are non-diseased intact. Those operations often are less invasive and can enhance recovery. As we're not doing as big of an operation. We're going to talk about the most common joints replaced in the United States shortly, and we'll talk about expected recovery success, and how long they last. In America, we perform well over 1 million joints every year. We performed in 2008, or 2018, which was the last data that we had, 700,000 knees were replaced in the United States. 400,000 hips were replaced. We replaced about 50,000 shoulders and lesser amounts for ankles, elbows, wrists, and the small joints in the hands and feet. And after the talk, I'll show you some examples of finger replacements, ankle replacements, and toe replacements. It is expected that by 2030, over 1 million joints will be replaced annually in the United States alone. And we talked last time a little bit about the gentrification of the United States, i.e. we're getting older, and the need for more orthopedic devices and joint replacements expected in the future. What exactly is a joint replacement? And I touched on that a little bit. A joint replacement involves removing parts of or all of diseased joints and replacing them with new metal and plastic joints. Oftentimes we use ceramics and other materials as well. For example, I just showed you the knee replacement, which is made of 3 parts: femoral compartment, tibial, and the plastic insert. There is a plastic button that articulates with the femur too, so the patellofemoral joint is replaced. In some hip conditions, the ball is replaced, leaving the socket intact. And this is an example of one of those prostheses. This is called a TARA, a total articulating replacement. This was common several decades ago when people had avascular necrosis of the head, one of the forms of types of inflammatory processes which damage the joint. And you could actually replace the femoral head and leave the socket. That has morphed and changed, and I have some other examples. But sometimes you don't have to replace the entire joint. You just replace the part that is injured or broken. And that can decrease recovery and decrease pain. We talked about the different parts of a knee replacement, and so I'll move through that. But again, there are several parts. Hip replacements actually has several parts as well. For example, I think I shared with you last time that not only am I a surgeon that has done many thousands of hip replacements and knee replacements, but I've actually had 2 myself. So I'm a little bit experienced in that way as a patient and as a surgeon. I think it does help me relate to people so I understand what the pain that they had before the procedure is. I can tell you if what the procedure is like, how much it was, how painful it was, what to expect, etc. But I have 2 of these. This is a hip replacement where there's a titanium stem. There's a hydroxyapatite coating on it, which is what your bone is made out of. So your bone thinks it's bone and your bone heals directly into the implant. This is a ceramic head, which is a low friction. This is a ceramic socket. So there's very low friction. We use these in younger active individuals. And the cup is just a hemisphere with the same material that we put in your socket. This is an example of one in a model where we've placed this implant into the bone with a ceramic ball cup, and the hip moves the way that it did. The benefit is it doesn't hurt anymore. All your muscles, ligaments, tendons, they're still there. How long is the recovery for a hip replacement or a knee replacement? And that depends on many factors. The most important is the original disease. There are many different reasons people seek joint replacements. Those could be inflammatory arthritis, like rheumatoid, for example. They could be from trauma, like car accidents that break the bones, and therefore the bones and joints deteriorate and get arthritis. It can be from osteoarthritis. In fact, there are over 100 different types of arthritises that we talked about at our last visit. It also depends on the length of disability and the degree of deformity and the duration of the disease. How long have individuals been suffering, and what is the joint like after all those years? Is it significantly deformed or relatively well maintained? Recovery recovery time can be affected by the health of the individual as well as the support network of the patient and the availability of local resources, i.e., I do think that some individuals do better when their mates are home or their family is home to assist them and encourage them. And I think that availability of local resources like physical therapy, occupational therapy, home health care, Meals on Wheels, all those things can assist in the recovery. In general, however, most people can bear weight immediately on their joint replacements, and many achieve a functional range of motion in 6 weeks. When I say functional range of motion, I mean the ability to do most daily tasks without hindrance, like put on your socks, put on your clothes, drive a car, etc., walk around the block. Most can return to activities, including recreational activities like golf or sports or riding a bike or a motorcycle or a horse, within weeks to months, depending on, again, the severity of the disease, how the procedure went, how the recovery went, etc. Often people ask me, how long does a joint replacement last? And it depends, again, on several factors. It depends on the host, i.e. the patient. And one of the things that contributes is how much do they weigh? I'm not ashamed to say I weigh about 100 kilograms, sometimes to my chagrin, but that correlates that I'm putting more weight on that implant than the ideal body weight 135, 140 pound female. So my implants may wear out faster because of the stress placed upon them. It also is affected by their activity level. Those individuals that are highly active can wear their implants out faster than those that are not as active. And age and general health contribute to the longevity of the implants as well. However, it is expected that a well-performed total knee or total hip should last in America 15 to 20 years or longer. And as implant designs are improving and evolving, as the way we put the implants in evolves and improves, we fully expect that the implants will last longer because of materials and the ways that we put them in. Any questions so far? So I'll take questions. I did bring some other examples that I thought would be interesting for people to see. We talked about knee replacements and the types of knee replacements. This knee replacement is a somewhat special one. It actually is made out of ceramics. It is a low friction implant. Sometimes we put these in people who are allergic to metals. And one of the things that can occur is when we put in implants is about 1 in 20,000 individuals may have an allergy to one of the materials, i.e. a nickel allergy. Your surgeon and physician probably will talk to you about any allergies you may have. If you have a nickel allergy, we would substitute the metal components with ceramic components. But this is a low friction, non-nickel implant. This, for example, is a partial knee replacement. And I showed you a little bit before. If the entire knee is not diseased, you can replace just part of it. And the benefit to this is a much less of an operation, smaller incision, shorter recovery time. It is something that's considered minimally invasive. It does have a rather narrow indication, however. So we don't put those in everybody who has just arthritis in one part of the knee. That is a specialized device. This, for example, is an elbow replacement. The elbow is a complex hinge, and it can become arthritic or damaged from fractures, rheumatoid arthritis, other diseases. And we are able to replace that hinge by putting part of this in the humerus bone and part of it in the ulnar bone and recreate that hinge. Sometimes we add a little button that's adjacent to this on the radius bone, the other bone in your joint, your elbow joint, and replace the entire elbow with those components. We can even do toe replacements and finger replacements. And this is an example of a device that is made to replace a painful great toe. Dr. Kennedy, my associate and partner, is going to talk to you a little bit more about those. But you are able to replace toes, fingers, thumbs for arthritic conditions. And in select individuals, we will even be able to replace the ankle joints. Earlier in my career, I did work with the Food and Drug Administration on certain ankle replacements. This was one of them, which actually did not pass the FDA. But in isolated individuals with very specific needs, you can replace their ankles with increasing success. And that's really all I got. If there's questions, I'd be glad to answer those for you.
Yes, thank you, Dr. Goetz. There were a few questions. The first here, is the decision to, as of what kind of joint replacement you use, made prior to the incision being made, or is that made at the time of incision and you get in there and see?
In my practice, we have a very good idea of what implant that we're going to use and why. We have a pretty good idea of what sizes we're going to need. And within advanced technology, we actually are able to preoperatively plan the operation, so we know exactly what size, what weight, what model the implant is going to be. Oftentimes we use CAT scans and other imaging devices to help us make those measurements and make those decisions preoperatively.
Okay. Is there a BMI limit for joint replacement?
That is a really, 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 really good question. And it's something that we, as your healthcare partner, will talk with you about. For me personally, I think it is variable. However, several organizations have given physicians some suggestions in terms of what is appropriate and what is not. As we know that those individuals with higher BMIs have significantly more risk of perioperative complications, including infections, blood clots, intraoperative complications like fractures or nerve injuries, primarily because of the difficulty in performing the implants in people of very large stature. So it would be wonderful if everybody was ideal BMI, body weights. But the answer is that the higher the BMI, the more risks that the patient may expose them to. And oftentimes we will suggest partnering with them in terms of decreasing their BMI so that they are a better and safer surgical candidate. I hope that answered your question. And I did not give you a number on purpose. I think it's a discussion that you have with your surgeon, your family, and the patient.
All right, one more for the sake of time. How much discomfort do you need to be in to consider a knee replacement?
I think that's a good question too, and I think that's very subjective. I see people with what I would consider early to moderate arthritis of the knee that consult for possible knee replacements. And I see some pretty incredibly bad knees that I'm surprised that people are even walking on. I think the patients have their own tolerance for how much pain they have. And it goes through the full spectrum. However, generally what I recommend and I counsel people is that when the pain and or secondary symptoms such as stiffness, deformity are to the point where they interfere with their abilities to perform their activities of daily living and pursue their recreational interests, that would be a time to schedule an appointment with your orthopedist to discuss joint replacement.
Thank you so much, Dr. Goetz. And to all of you who have joined us today, we will send out an email as a follow-up to this session, and that'll include links to the two previous sessions that we've had already as well. And just a reminder, there are 2 links in the chat box. One is to link for additional questions or to request our appointment. And the other one is going to be a link to the last virtual orthopedic session that we have. This final session is Tuesday at 2 o'clock, May 18th. That'll be with Dr. Christopher Kennedy, foot and ankle surgeon, and he will discuss solutions for ankle pain. We hope you've enjoyed today and hope that you join us back again on the 18th.